infection. Okay, so like when you get SLE, you may have uveitis, or you can get keratitis. Also in SLE, when you start steroid, patient is immunocompromised and more susceptible to infection. Okay, Aziz.
Okay, Prof.
Inflammation does not equivalent to infection lah, tapi it can be caused by infection. Okay, any more questions before we? Yeah, Aziz.
I have one more question.
Yes.
How to really differentiate between eye pain and then a pain that radiates to the temporal and head, and one more is the headache itself.
Okay, dia dah buat medical ke? Dah pergi neurology posting ke?
Neuro belum.
Okay, so basically these all relate back to headache. Okay, nanti when you do a medical posting, they will say ada algorithm for headache. So they will put, okay, if you get headache, temporal headache, occipital headache, generalized headache, stress headache, migrainous headache, and also headache related to the eye or adjacent structure to the eye ke, to the ear ke, to the nose ke, to the mouth. Kalau macam dapat dental caries also, you dapat toothache, sakit kepala juga kan. So from there, there's many other differential diagnosis. So kalau you nak tahu it is from the eye ke adjacent structure ke, you ask the patient, where do you think that this pain comes from? The first, then they will say, based on what they think, they say, okay, it's from the eye. Actually, it goes radiated on the right side of the head, but my left side is okay. So you may be able to point that the problems come from the eye. Faham tak?
Faham, Prof.
Okay. Nanti you go to medical, you dapat that headache chart algorithm tu, you'll be able to sort of like understand. Okay. Any more questions?
Okay, thank you, Prof.
Any more questions? Tak ada. Okay, we. Okay. Kenapa stop sharing tu? Okay, now, boleh tak somebody describe to me what you see in the right eye? Boleh. Silakan. Good. Okay. The opacity, Amirul, kejap. Okay, okay, tak apa, cakap opacity dulu. Do you think the opacity ni generalized ke localized? Okay, so bila dia generalized macam ni, you can kata haziness pun boleh. Okay, cornea haziness lagi. Tu nampak tak pupil tu, macam mana pupil dia? You rasa berapa mm tu of the lebih kurang lah 2 to 3. Look at the left eye. That is what 2 to 3 looks like. So what do you think? Orang sambil yang kecil tu depan. So 5 to 6 lah kan. So bila 5 to 6 kita panggil pupil tu apa? Normal, mid dilated, dilated. Yes, it's mid dilated. Anything else? Lepas you dah nampak pupil ni, how about the iris? Anything on the iris? And how about the shape of the pupil? Normal ke abnormal? Is it round? Is a bit abnormal kan macam mana? over, so it's okay. Lagi, apa lagi? How about the iris? Whitish. Okay, anybody else nak tambah kepada Amiro punya finding? Ada tak? Siapa-siapa nak tambah? Okay, what you can see here is bila kita kata redness of the conjunctiva either hyperemia, usually we have to differentiate, is it generalized or is it localized? Because like macam scleritis, sometimes dia ada localized redness. Okay, this is generalized redness ataupun hyperemia, agree. Yes, you nampak yang macam whitish keliling ni, this is more likely arcus sinatus. Okay, and then you can see generalized haziness, if you compare to the right eye, it's very clear kan? So it's generalized haziness here. You can see the pupil is like mid-dilated. Nampak tak irregularity of the pupil? It is not round. It looks a bit oval. Lepas tu ada macam jagged-jagged sikit, macam it stick to the ni lens. Tengah-tengah ni adalah lens. So dekat tengah-tengah lens tu you can see it's like sticking to the lens. Okay, whereas if you compare with your left eye ni, white, clear, isn't it? Okay, round pupil to 3 mm like. And then you can see the iris detail yang one chocolate. Here you can't really make up the iris detail. Okay, Wei, did I miss anything, Wei? Okay, next.
Sorry, Prof. I punya laptop ada
Salah.
tak ada miss. Difficult to change the interface.
Alright, okay, next. Ada lagi gambar lain ke? Okay, while we are changing the interface tu sekejap.
Sorry, Prof. Should I change the next slide?
Yes, go ahead.
Okay.
Alright.
Prof, for the picture just now,
Wei-Hua, yeah.
can we say that the pupil margin is not clear over the nasal side?
Okay, this is because it's a true 2D picture. But I think if we see a 3D, you can see it's sort of like generalized. We generalize and more prominent perhaps on the left side on the nasal side or temporal side. This is most likely, I think this is most, if let's say you put it up, this is a nasal part, so you can see on the nasal part. But generalized haziness in general, when you say generalized, meaning that semua kena. Kalau if you say it's localized on nasal part, then you have to think about other differentiated processes.
Okay.
Okay, all right, before we go to the next slide, Jaslyn, what do you think will be the visual acuity of the right eye? Jaslyn Farisha.
The visual acuity,
rasa-rasalah lebih kurang sebelum you ambil lagi dia nampak macam ni kan? Rasa macam mana visual acuity?
sebab dia tak nampak kabul fully, so maybe 6
Six berapa?
ataupun 6.
Tak
Maybe
dengar Jaslyn?
sekejap. Doktor dengar ke?
Dengar. 6 berapa?
6 18.
Okay. You rasa could it be 680 when you have corneal dysplasia? Could it be worse than that?
It can be worse.
How much worse can it be?
Maybe until tak nampak 6.
Memang dah tak nampak 6, 618 tak nampak 6 lah tu.
660.
660. Okay. All right. Wait, can we see the next slide? See, the visual acuity is actually 260. It doesn't correct with the pinhole. Anything that corrected by pinhole, meaning that there is some reflective
Yes, ZFP2.
can correct up to certain
Account name I sent to you. I sent to you.
okay. And then the anterior chamber just now because it's a 2D, it's not a 3D. Actually, the anterior chamber is shallow and the left eye is moderately shallow. The intraocular pressure is 65 and the other eye is 18. Okay, so based on this and this setting, do we have anything else after this, Uwe? Okay, never mind. What do you think up to this? Just now we are thinking of 3 differential diagnoses: uveitis, keratitis, acute angle closure. Alia, what do you think? Alia Adila. Now tadi is both based on the history, and now we have the finding. So what do you think, Alia Adila?
I think it's acute angle closure glaucoma
Why made you say that, Alia? Based on the history and
because
also the finding.
the patient intraocular pressure is too high, 65,
Okay, that
and
is
then it is sudden worsening of the blurry of vision, painful,
okay.
Mhm.
Okay.
and then it is unilateral. It affect one eye, not both. Okay, and he has halo.
Okay. Angle closure, sometimes acute angle closure can affect 2 eyes. Uveitis can affect 2 eyes. Keratitis usually 1, but it can also, the rare case, get 2 eyes. Okay, so you cannot say it's just 1 eye because it's like that, kan? Lagi, okay, your point is high intraocular pressure, sudden in onset. Lagi.
Shallow anterior chamber.
Shallow anterior chamber lagi. Kelti pula. Kelti kan? Kelti ke
KT doctor.
Kirti. Okay, sorry. Okay, apa lagi?
The patient, based on the picture, the patient had mid-dilated pupil on the right eye.
Good. Okay, mid-dilated pupil. Okay. Lagi in the history, anything else apart from halos, headache, pain? What else in the finding that does not come into keratitis or uveitis? Okay, all right. Secondary rhythm, yes, but you know the one that he has on and off pain too, because usually when I remember my tutorial, I was saying that you have your mid-dilated pupil masa bila when you were in the dim light, kan? At dawn, at dusk, kan? So when you have dawn and at dusk or in dim light, when you become mid-dilated, that is the time when you develop pupillary block. And some of these pupillary block, they can unblock themselves. That's why they are the pain, redness, and then after that disappear. But at one point when it cannot unblock themselves, that is where you get acute angle closure, like what happened to Mr. Wei. Okay, that is a possibility of that. But based on that, we have not excluded uveitis yet, because uveitis also can have recurrent, whereby sometimes the recurrent redness, reduced vision can actually resolve by itself. But what makes it different from pain. Pain, as what you say, pain in acute underclosure will be higher than pain in uveitis. But uveitis also may have component of papillary block. Because uveitis tu nanti you will learn there are a lot of inflammation and the iris becomes sticky and stuck on the anterior capsule of the lens. And bila dia stuck to the anterior capsule of the lens banyak-banyak, dia akan jadi macam papillary block juga. Okay. But here obviously it is not keratitis based on the finding because there is no localized opacity. There is no localized discharge or epithelial defect. Kan? Kalau keratitis, corneal ulcer usually ada epithelial defect and the epithelial defect will be localized to one area. You won't have generalized haziness as in this patient. Okay, faham tak? Okay. Wei, ada lagi ke? Nak tunjuk apa-apa lagi ke apa?
Yes, Prof. Ada posterior. Kejap
Okay.
I tunjuk.
Alright. Alright. Wait, kenapa right and left sama je? Okay, never mind. Let me ask apa? Irfan Haziq. Can you
Yes, Prof.
describe the fundus finding on the right eye?
Okay. For the finding on the right eye, the cup disc ratio is
I kata start with what?
Huh?
Shape.
Oh, shape. Sorry. The shape is oval in shape.
Kejap. Kenapa? Okay. Is it oval? Ini right eye Right eye. Is it oval or is it round?
Round in shape.
Round in shape. How about the margin?
The margin is well defined.
Okay, lagi.
The color is pale.
Palish, okay, alright.
Palish, and then the cup disc ratio is around 0.7, I think. 0.7.
Is it 0.7 or is it nearly 0.8?
0.8, Prof.
Okay, lagi, go on.
There is a hemorrhage on the disc.
Good, very good. Okay, nampak ni hemorrhage on the disc. Okay, lagi.
Then I'm not sure, but the dark color around the disc, is it atrophy, Prof?
What did I tell you? Very papillary.
Papillary atrophy.
Okay. Alright, if you look carefully, you nampak tak all these vessels? Ni nak cakap pada yang semua yang ada masa kat klinik semalam. This is what we call nasalization. It goes to nasal. Ni pun kita akan nampak nasalization. Nampak tak? It goes like this. Right? So this is nasalization when a lot of nerve fibers dah mati kan? Then you can see bulat-bulat kat tengah ni yang I call what? Lamella dot sign or bionitic sign. Nampak tak? Okay. Alright, that is on the right eye. Somebody describe the left eye. Bushra. Can you describe on the left eye ke Bushra? Okay ke? Boleh cakap ke?
Doktor dengar ke?
Boleh.
Okay, boleh cakap. For the left eye, the shape is round.
Okay.
It is, it has well-defined margin.
Well-defined margin. Okay.
The color is pink.
Okay, alright.
And then cup to disc ratio, I would say 0.8.
Okay, alright. Go on.
There's
Go on.
There's like C-shape, blackish.
Okay, this is
around.
what we call pre-papillary atrophy. Okay, lagi.
How about nasalization?
Yes, good.
That's all.
That's all. Okay, you can see nasalization here. That's quite extensive. Atrophy. It's a deep cup, well, it's rather small. Okay, and nasalization again, nampak tak all the vessels ni towards the nasal. Usually dia akan kat sini. Then it goes like that. And some what I teach you about apa? Beam port sign. Nampak macam vessels ni pergi situ hilang. Betul tak? This one pun almost a beam port sign. Nampak tak? Dia pergi inside and sort of okay. Alright. Okay, at this point, based on the funder's findings here, what do you think this patient have? Siapa yang boleh jawab lagi? Afifah Muhammad Amin. Type up your finding, history.
I think primary angle closure glaucoma.
Yeah, so now tadi dia ada optic neuropathy. This is optic neuropathy because we can see the coverage ratio is increased. And there is also a lot of other sign. So this is when the G comes in. Tadi kita kata acute angle closure sahaja without the G. Once you see the evidence of the G here, then you can see primary angle closure. How about the left eye? The one that does not have any symptom of acute pain. You think the left eye also have primary angle closure glaucoma? Afifah Muhammad Amin. Afifah sudah lari.
Sorry Prof, tak unmute tadi. Rasa left eye pun rasanya ada juga. Primary.
Rasanya ada juga ke? Ada juga.
Ada juga.
Apa? So
Ada juga.
your diagnosis fully bilateral?
Bilateral eye primary angle closure glaucoma.
Bilateral primary angle closure glaucoma with acute angle closure
Okay, angle closure.
on the right eye.
Yes, Prof.
Okay. Alright. Ui, ada lagi ke gambar lain?
Prof boleh tanya ke?
Boleh.
Prof, tak ada gambar dah. This is the last one.
Alright, thank you. Yes, Wei Hua, you want nak tanya apa?
Kalau glaucoma suspect macam mana?
Oh, okay. Glaucoma suspect ni, they can come in apa ni? They can come in many. Okay, when we diagnose glaucoma, remember what was the criteria when there is a presence of structural and functional changes of optic neuropathy, kan?
Yes,
And
Prof.
that there must be changes in the optic nerve and also a typical visual field changes. Okay, and then we identify IOP as a risk factors. Okay, the suspect who come from the IOP, meaning the IOP dia high, tapi there is no glaucomatous optic neuropathy. So kita boleh kata dia suspect and then we can put him under the patient into ocular hypertension. Or the other thing is when you see the optic test. Okay, we know we define changes of the optic test is bila cup to this ratio more than 0.7 is glaucomatous. So which is less than 0.7 is non-test. Okay, but just remember when we have the tutorial, I was telling you about the presence of particular atrophy, kan? And then other nasalization, all those kind of things. So if any cases that when you do a fundoscopy, you think that this cup to this ratio is 0.7, but not going to be 0.8, you can put this patient into the category of suspect. But you have to analyze other risk factors also. Other risk factors usually when, for example, in this patient, he has a family history. That is another plus point as a glaucoma suspect. Because we know there is a genetic component. So the likelihood, if you have a family history of glaucoma, likely chances for you to become glaucoma is high. So we want to detect early kan as part of prevention of blindness, and we want to treat or prevent blindness later on because this is the cause of irreversible blindness. So we usually put all this type of patient under glaucoma suspect, and usually we'll be following up this patient quite regularly, yearly, especially if the patient is more than 40 years old. Okay, that
Okay.
is just a very quick guide of what glaucoma suspect is all about. Okay,
Okay, sure, Prof.
alright.
So can we say that the left eye could have some but then the right eye already is established diagnosis of
Yeah.
glaucoma. The left,
It,
could we
okay.
say glaucoma suspect?
Let's say like this. Because I don't want you to go into detail, but since you bring it up, memang in angle closure dia ada pelik sikit. Dia ada satu memang ada primary angle closure glaucoma. Okay, dia ada kita panggil primary angle closure suspect. Meaning that primary angle closure suspect is bila one eye is already developed acute angle closure, the other eye has a shallow anterior chamber. In this case also the left eye have moderate shallow anterior chamber kan? You can see from the slide. Okay, when they are already have moderate shallow anterior chamber, likelihood for this eye to become primary angle closure. When I say primary angle closure is another entity. Dalam primary angle closure ni, you may have high IOP that you need treatment, but there is still no glaucomatous optic neuropathy. The thing is the G need to occur. So number 3 baru primary angle closure glaucoma because the G comes in. So in this case, most likely on the left eye, the IOP was normal, 18, and the AC is shallow. There is some glaucomatous changes here, but we have to, whatever we see here is structural damage. We have to see pula dengan functional damage, which is your
Visual
visual
field.
field. Okay. Alright, some people have a large cup, that's why nampak macam 0.7. But actually when you calculate based on the size later on, it may be just 0.6, for example. So once you establish this patient is PAC or PACS, then you still need to treat the patient. For example, in PACS patient, in acute angle closure, kan kata pupil block, definitive treatment is to laser kan? Break up the pupil block. So preventive measure on the left eye is to do similar laser
Laser
iridotomy.
iridotomy.
Yes. But if there is no increased pressure, you buat laser peripheral iridotomy, that's it, tutup cerita. And then you follow up. Okay. And bila IOP shoot up, tapi tak ada lagi the G component, you may want to start treatment, medical treatment for example. Then slowly as the patient age, sometimes they will change into the G part. Jadilah PACG. Okay, is it clear, Wiwa?
Yes. Thank you so
Alright.
much, Prof.
Okay. Any more questions before we wrap up here?
Prof, is this a present of the bionetting sign on the right eye?
Aha. Macam mana? Tak faham tu, Aziz?
Alif.
Alif ke? Oh, okay. Oh, Macam Aziz. Okay, Alif. What was your question?
Ada tak present of bionetting sign on the right eye tu?
Right eye ni? Bionetting. Nampak tak? Yang bulat-bulat macam vacuum kat tengah-tengah. Tu is lamella dot sign or bionetting sign lah tu. Sikit-sikit dah ada.
Oh, okay.
Kan remember I said all these nerve fiber dia masuk kat dalam macam set kan, collagen punya set tu, bulat-bulat kan. So bila nerve tu dah mati, you can see ada bulat-bulat ni. Nampak tak? Okay?
Prof, kalau yang bin port sign on the left eye tu, is it on the 6 o'clock ke?
You all nampak tak I punya arrow? Tak nampak
Tak.
Wait, can you show the ni sekejap since you are sharing the screen with your apa tu? No, on the left eye. This is the one, the beanpot sign.
Sorry, Prof, show what, sorry?
The beanpot sign when the vessels goes in and disappear.
Oh, okay. The left eye, right?
Which one beanpot sign? Yes, this one, the one. These two vessels, nampak tak dia hilang? Zoom, tak ada kan? That is the beanpot sign. Nampak tak, Alif?
Nampak. Betul lah, 6 o'clock.
The rest nampak tak?
Nampak
Nampak, Prof.
Prof.
Kalau tak nampak ni banyak, tinggal beberapa hari sahaja lagi. Okay, apa lagi? Ada lagi soalan tak? Before we wrap up. Okay, so today you learn more about acute angle closure, and in this case is acute or chronic. Okay, and then you see the changes and everything. This is the cases that you need to identify when you become a medical officer later on and refer to us immediately. This is part of the ocular emergency. Yang ni tak boleh tunggu-tunggu, tak boleh buat referral. Okay. One thing, patients in pain, redness, and the vision drop drastically up to counting finger. So all these need to be referred immediately. Okay, faham tak? Okay, alright. So if there is no more question, we can.
One more, Prof, one more.
Okay, sure. What Alif, yeah.
Basically kita tak boleh nak differentiate between the uveitis dengan primary angle closure glaucoma dalam klinik.
Boleh lah, sebab kalau uveitis, would have the glaucomatous changes ni.
Bukan, I mean clinically, not in the examination.
Clinically maksudnya in the history ke?
Yeah.
In history, yes. Usually you will have history of recurrent redness ni. Not hari-hari, dia akan ada sebulan sekali, tahun lepas, macam tu dia punya recurrent. And then dia akan bertukar mata, sometimes right, sometimes left. And usually patient with uveitis, kalau it is caused by systemic disease macam SLE, rheumatoid arthritis, you will have history of other systemic illness lah. Macam dia kata, I have joint pain, I cannot, when I walk, when I cannot ride, rheumatoid arthritis for example. Or if there is related to infection, then you can get macam tadi somebody was asking, is there going to be history of fever? So possible juga if you get uveitis, you may have other, let's say, TB uveitis or Bartonella-cyst for example. Bartonella-cyst ni cat scratch disease. Dia akan ada history of having cats. And then baru je recently been scratched. Then dia ada a bit of fever. Lepas tu dia rasa reduced vision. Now, that is another form of uveitis. Faham tak, Alif?
Mostly dia secondary cause lah.
Yes, uveitis mostly are secondary cause, and uveitis usually ada, kalau tak systemic causes, dia mesti ada ocular causes.
Okay, Prof.
Dia tak boleh ada uveitis yang idiopathic terjadi dengan sendiri. Tapi all uveitis kita kena exclude potentially or primary cause. Bila kita dah exclude semua, kita dah ambil blood, semua negatif, baru kita kata this is idiopathic anterior uveitis. So meaning that kalau nak datangkan idiopathic tu, kita kena by exclusion. Faham tak, Alif?
Faham.
Okay, alright. Anybody else? Any question?
Prof,
Ya.
kalau macam tadi Prof cakap uveitis ni macam usually recurrence kan? Boleh ke patient tu after a long term dia develop uveitic glaucoma?
Boleh? Yes. uveitis, sebab macam I kata tadi, kan tadi ada I mention, sometimes uveitis also can have acute pupillary block. Or on the long term, bila kita dapat uveitis ni, remember bila uveitis ni, uveal tissue termasuk iris tu adalah uveal tissue. Once dia ada inflammation, dia akan jadi more sticky. Dia sticky, dia akan satu menyebabkan pupillary block. Satu lagi, bila banyak sangat inflammation ni, dia ada banyak glycosaminoglycan and also macrophages, dia akan block pula dekat angle. Remember when we show the picture of an angle, so dia akan block pula kat angle. Dekat angle ni bila banyak inflammation, dia akan form pula peripheral anterior synechiae dekat angle tu. And then this will in the long term increase intraocular pressure and lead to or if it's a known case of uveitis, usually dia banyak sangat attack, kita akan bagi dia steroid. A long-term systemic steroid oral prednisolone for example, and also a long-term topical steroid also can lead to secondary glaucoma, meaning that they can cause increased intraocular pressure and later on lead to glaucoma. Your question is very good because that is what can also happen in this patient. But the history dia akan berbeza lah daripada PACG ni. Kan akan dengar history yang panjang, dia ada red eye, reduce for a long time. Yang baru dia kata, oh sudden pain, headache, semua-semua tu, then maybe at that point of time, kita dapat secondary.
Okay, thank you, Prof.
Okay. More? Okay. So if there is no more questions, I hope you benefit from here and understand about acute angle closure properly, how to differentiate it from the other two. Because the other two also is important because the other two also need urgent referral. Okay? Alright, especially keratitis. Alright, so all the best. I'll be seeing you around again next week kan? Ada lagi kan last week kan? Okay. Alright, for those in my team, nanti Alif, Bushra dengan siapa lagi satu Alif?
Alia bro.
Ha?
Alia.
Adilah.
Ya.
Okay, nanti at the end, kena ada, you all habis berapa hari bulan? 16 kan?
Yes.
16, I will not here because I will be in time for your combo. Can I have the assessment with you 15 nak tolak sebab lagi Penang. Tuesday petang boleh? Ya, Tuesday petang. 14.
Dekat bilik Prof?
Boleh.
Boleh.
Okay, alright. All the best to the rest.
Okay.
Okay, see you around. Thanks a lot, Dr. Uy.
Thank you, Prof.
Okay, bye.
Thank you, bro.